so glad that you're here. And I'll go ahead and turn it over to our neurologist, our fabulous neurologist, facilitator, moderator. I started to call you the Oprah of the Parkinson's world. I don't know if that's going too far.
Okay, well, thank you. Hi, everyone in virtual support group land. Thank you so much, Tanya, for joining us, and thank you, PMD Alliance, for hosting. So it's with great pleasure that I want to bring us Tanya Simuni today. She's been a mentor, a great advocate for women in medicine, really helped guide me in my career and with patient care and so many other things. She directs the Northwestern University Feinberg School of Medicine's Movement Disorder Center, and she's just so prolific in terms of her work. She's done investigations. I was going through her various subjects that she's done research in, and I really could not find one area that she hasn't actually researched in Parkinson's disease. So we can have a really rich discussion, I think, today, but she's just been a phenomenal leader in the field of clinical trials and trying to instill hope and bring new medications to the forefront for our patients with Parkinson's, along with being so knowledgeable about other areas as well that we can touch on. So Tanya, thank you so much for joining us, and thank you for being who you are. I wanted to start maybe today with just, maybe you can introduce a little bit about why you became a neurologist, why movement disorders and Parkinson's disease, and why research in clinical trials.
Wow. First of all, I really appreciate the introductions, and you're way too nice. But it's my honor and pleasure to speak to the group. And obviously, I second that all of us are living in unprecedented times, and having a platform to have virtual connection and being being physically distanced, but socially connected is probably the right way of putting that. So let's switch over, and we exchanged some emails with Dr. Isubramanian, and we purposefully decided to keep it as an open mic conversation and not a single topic conversation. So I guess you're hitting me with the first open mic question, right? Why neurology? I guess existential question. When the students ask whether they should go into neurology, I usually respond that it's a very cerebral and very logical field. I am actually very mathematically minded, and to me, neurology is one of those specialties that allows you to arrive to the conclusion, walking through very calculated steps of anatomy, physiology, pharmacology, and then get there. From neurology to movement disorders, I've always been fascinated by combination of really rich clinical exam. It is one of the few specialties in neurology nowadays that we order less tests than the other subspecialties, and largely our diagnosis is based on the history taking and the clinical exam, and it always fascinated me, and I love pharmacology. So in between the clinical exam and pharmacology, I guess that was the decision, and again, I never regretted it and enjoy every minute of it.
That's awesome. And tell us a little bit about clinical trials and doing clinical trials in the world of Parkinson's disease, because I know you are a formidable clinical trialist. You fight to get these studies done despite all odds. You are meticulous in your research protocols, and you know, it's an uphill battle. So you know, it's not an easy area of study. So maybe you could tell us a little bit about what your you know, what is your sort of what drives you in this space, and a little bit about doing these trials.
I think that what drives all of us is the same. It's the desire to find that one pill or one intervention that will cure the disease once and forever, or prevent the occurrence of the disease. But in order to get from where we are now to that point, it's a journey, right? And every single drug that your doctors have prescribed to you has been in a clinical trial, right? So not a single pill that you're taking now has arrived to the market, to the pharmacy, without being tested in well-designed clinical trials. right? So all of us want better therapies. All of us want new therapies, but in order to get there, those interventions, and I'm not speaking exclusively about drugs, the same rigor applies to exercise interventions, um, the neuropsychological interventions, and so on, right? So we need to start with the well-positioned question, why this, and I'm a clinical trialist, as Indra has said, and I deal mostly with the drugs. So I will use drugs as an example, but you need to understand that it's not strictly applicable to the drugs, right? And I will give you the example of an exercise study that is being launched now. But you need to start with the right scientific question. What am I trying to test? And then, does this molecule, drug, or intervention, is that the right one to answer my scientific question? And then, based on these two variables, you need to define what are the characteristics of the people that I want to enroll, what are the measures that I want to apply to answer my question, what is the duration of the study that I want to do. So all of these are the methodological questions that at the end of the day will allow you to reliably answer the question, does it work or not, right? And as a clinical trialist, I cannot resist to put the pitch that I do to every single patient coming into my clinic. When they're asking the question, doctor, when there will be new therapy, my response is, it's equal my responsibility and yours to contribute to that. Mine to develop those new drugs, yours to participate in the clinical trials, right? So did it answer your question?
Yes. Could you tell us, Tanya, a little bit about why, there's a lot of things, people always bring research in from cells. This seems to change something in a cell, or even something in a mouse model. And they say, should I take this drug? Should I, what should I do about this? And this could be said even with, COVID right now, and some of the anecdotal things that we are seeing with some of the medicines that are potentially, treatments like hydroxychloroquine. Could you tell us a little bit about what the procedure is to take a medication from maybe a story that it helped one patient, like some of the chemotherapeutic drugs that you were just studying, for example, in Parkinson's, and then to take it from that story maybe, or a mouse or a cell, and then bring it to market? What is the sort of process? Because I think that's helpful for people to understand, because people always say, why don't you just give this to me? It's already on the market, for example, like is Radipine.
Right. And the second question, why does it take so long?
Yeah.
Right? So obviously the stages of the drug development are the molecule is found in the lab, right, and characterized in the lab, that this is the mechanism of action of the molecule. Then it has to be taken into the animal models. And the big challenge in Parkinson's disease, that the animal models are not equivalent to Parkinson's disease. And that's one of the reasons why there is such a huge disconnect between long list of molecules and drugs that have been effective in the mouse models and much shorter list that work in humans, right? And my joke is always that we long time ago have cured Parkinson's in mice. Unfortunately, that has not yet translated to the person living with the disease, right? So once the molecule has been tested in animal models, and again, the key to that is that the animal, we still do not have the animal model that behaves in the same way as the disease behaves in humans, right? Historically, most of the animal models were toxin models. You probably have heard about MPTP models, right? So it's the toxin that is administered to the animal. It's usually rat, and the animal develops Parkinson's-like features, but it's not Parkinson's disease. It's acute hit. Those animal models are predictive for a number of drugs. They have worked very well, for example, to assess the effectiveness of your levodopa, or to assess the effectiveness of molecules that work for dyskinesia. But those animal models are much more challenging when you study the drugs that potentially are tested to slow the progression of the disease. So in the animal model, the questions that are being asked, does it work, right? Does that prevent the development of symptoms A, Parkinsonism, right? What are the potential side effects? What is the dose, and is there dose correlation, right? And then all that information, what kind of biological readouts can we get? Can we get some kind of the readout of protein levels? Because it's much easier to look at the tissue of the rat, right, than to go to the humans. And then all that data goes into the human development. And that's where you probably have heard about the stages of drug development, right? You know that stage 3 is the stage of the drug development that is taken to the regulatory authorities for the approval of the drugs. But you start with stage 1, which is giving the drug to usually healthy population with a single question: is it safe and is it tolerable? Once it passes that stage, it goes into the next stage of the development, which usually is called phase 1B, 2A, when you already test the drug in people with a disease. We're talking about Parkinson's disease. You still are asking largely safety, tolerability questions. Is it safe? Because the first and foremost question, is it safe to proceed with the further testing? And then in the same studies, you might also start asking the question, what dose should I take to the further development, right? What dose, what duration of exposure, what kind of the outcomes, aside from the clinical picture of the disease, we can assess to, you're building your building blocks, right? You're basically building your truck, right? You're starting with the engine, you're putting the engine in the body of the car, you're putting the wheels. So probably that is a reasonable comparison before the truck lives for the long distance trip, right? So, and then you move to the phase of the development of phase 2B. Phase 2B studies are usually the studies to have the early look at the efficacy of the molecule, right? And they're not large enough to make the definitive assessment, but that's why they're called early efficacy studies. And once the drug has passed that stage of development, it goes into the phase 3, which is ultimately the efficacy study. And stage 3 studies, pretty much your truck is built. It has passed the first, it has passed everything in the shop, right? And it goes on the long distance ride, right? And at the end of that long distance ride, you're answering one question: effective or not, right? And phase 3 studies usually are very straightforward because you've already prepped everything. And those are the data that goes to the regulators for the approval or disapproval of the drug. So a lot of you definitely come to your doctor's offices. My patients constantly come into my office and say, I read this about microbiome. I read this about probiotics. Why wouldn't you prescribe those to me? And again, the reason for that is that these are N of 1, N of 2 small observations, and we don't know how they will behave in large group of people. We need more data. And obviously, if it is something innocuous, and again, my typical response, if it comes to probiotics, I tell usually my patients, this is what I can tell you that we know today. This is what I can tell you about the safety. And these are the things that we just do not know. And based on those variables, it's joint decision. If you want to try probiotics, go ahead and try probiotic. It doesn't mean that I'm telling you that it will be effective. What I'm telling you that there is reasonable amount of safety data that it's not gonna hurt, right? On the other hand, you probably have heard about a couple at least drugs that do not fit that category of do not hurt, right? Dr. Subramanian was alluding to one of the cancer drugs that has any of you heard about nilotinib? So that's the drug that got a lot of publicity by now about 3 years ago, actually more than that, 3.5 years ago, being tested. It's molecule that actually in the animal models has promising data of having neuroprotective effect, meaning and possibly impacting the rate of progression of the disease. So a lot of interest in the science of the biology of the molecule. But that's the drug that has been developed for treatment of cancer. And a couple years ago, it was tested in a very small group of people, what is called open label study. So everyone knew that they were getting the drug. There was no placebo. The study was designed as the safety study, but the investigators reported a lot of super promising data on the effectiveness of the drug in people with quite advanced disease. And I don't need to tell you that people with progression of the disease things become more and more challenging, and they start gripping for the straws. So as the result of that publicity, hundreds and hundreds of patients with Parkinson's around the world, not only in the United States, started asking physicians to prescribe that drug. And again, based on the results of 12 people study, 12 participants, open label study. And physicians legitimately were answering that this is not the study to prove or disprove the efficacy. The drug has a lot of safety concerns. The drug has a lot of risks. So as the result of that uncertainty, plus tremendous publicity, 2 studies have been launched pretty much in parallel. One study was launched by the group at Georgetown that originally did the small study, and another study was launched by the Michael J. Fox Foundation, and I was privileged to lead that. And that was both studies with similar design, still asking the question of, is it safe and tolerable? So getting back to those stages of the development, it was a phase 2A study. And to fast forward, the drug at the doses that we tested in carefully selected participants, we basically excluded 40% of the people who were interested to participate in the study because they had some abnormal lab work, they had abnormal electrocardiogram or some other reasons. So in that very carefully selected group of people, the drug had acceptable tolerability. The study was not designed to demonstrate efficacy, but we obviously looked for that and we didn't see a signal of that. So we've presented our data publicly. The manuscript is in submission, but our message to the community that is a perfect example of overhyped expectation from the drug. And the drug is not gonna move forward for any further development. And definitely there is no recommendation to use that off-label. So that was a long-winded answer to your question, but an important question.
Okay, so to just break it down a little bit, so it sounds like our animal models that we have, so most of them are either mice or some primate, like monkeys and things like that models, we usually take something and make a lesion. So it's like one time we take a substance and kill some cells in the area that cause Parkinson's, which is not the usual model that would make sense to replicate exactly what happens in Parkinson's disease, which is a slow, progressive cells are affected over time and years. So we have this model where we do an acute injury, as Tanya was saying, where this area is affected, and then we try to study what we can in these mice and other models And then once we have a sense that that might work, then we go on to the phases. Phase 1 is, again, safety in healthy patients that don't have Parkinson's. And then we get into as the numbers of the phases go on. So 2, 3. So the third phase is when we're doing studies in Parkinson's disease patients, and we usually have a control arm and the actual patients that are getting the medications. But the middle phase is when we're increasing with safety in Parkinson's patients and understanding what these drugs do in Parkinson's disease. And how long do each of those phases take approximately, Tanya?
I guess there are two questions, right? How long do you need to test the intervention in individual person, right? And it depends what question you're asking. For the drugs that improve the symptoms of moving around, motor symptoms of Parkinson's, some studies are 12 weeks, right? Because it's the effect that you can see right away. For some of the questions, does it slow progression of the disease? That's where you definitely need to get into the longer studies. And that will be at least a year, and in majority cases, probably a longer duration study, right? But that is the duration of exposure to the drug in individual person, right? And then you need to add on all the time that takes to prepare the study, all the time that takes to recruit the participants, right? Because if your study requires 100 or 200 participants, you need time to recruit them, right? And you have to wait until the last person completes the study before you can get to the data analysis.
Okay. One of the problems with some of the studies in the past is that they often end up with certain types of populations of patients with Parkinson's. So a lot more Caucasians, a lot of men, often in affluent areas. What's your sense of how we can help recruit other patient populations like women, like other Latino groups, African Americans, and other patients that may not have access to our, urban centers that are in academic arenas that are often more private, sort of insured folks?
Dr. Subramanian touches a very important aspect, right? When the drugs are being approved, we need to demonstrate that we've demonstrated efficacy and safety in the population that reflects the population with the disease, right? And as she has clearly indicated, still more than 90% of participants in our studies are white, highly educated, fairly affluent population. Why is it so? Because again, studies take time from work or time from, you need to get to the center, you need to have enough of information about the studies. So how can we mitigate that? That's where a lot of effort is being put now to reach out to underrepresented minorities, to reach out to underrepresented socioeconomical groups. And we really need to be more creative, right? It probably is unrealistic that we'll be successful in targeting that diverse population if we continue to implement our traditional classical, the participant comes to the office and he has to find a ride to the office and get to the office at least once in 2 weeks and so on, right? That's where actually a lot of interest nowadays comes into virtual care. And again, COVID-19 has been incredible stress and incredible tragedy for the world. But one thing that it is teaching the medical field and clinical research field that we can do a lot of things remotely. So that's one of the ways to do that. But still, if you're trying to reach out to underrepresented minorities and specifically socioeconomical minorities, we need to make sure that there is a technology available for them to get on those remote visits. So there is no simple solution, but there definitely is, it's in the focus of every study. Every study is required and expected to recruit the population, at least to a certain degree, representative of the general community of people with the disease. And that's where the next phase of the studies that we have not so far we stopped on phase 3 of the drug development, right? That's what brings the drug for the approval. There is phase 4, what is called post-marketing studies. And those could be studying the approved drug for slightly different indication in the same population, studying approved drug for a different dosing and so on. But that's also where comes more experience of efficacy of the drug in more diverse population, because obviously once the drug is approved, it is available to hundreds times more of the people compared to what you've recruited into the studies.
Okay. Tanya, could you guide our audience here, and this will also be on tape and on YouTube, and so hopefully other folks will be able to access it as well. Could you guide people if they want to get involved in trials and in clinical trials in Parkinson's? What is your advice to them in terms of where to go? What types of people should be performing the studies? Do you have some guide as to how to prevent getting involved in maybe not the right organizations that are doing the studies? Not to be biased, but just in your opinion.
So obviously you need to talk to your physician, right? And express your interest and willingness to participate in the studies. And it doesn't matter if your physician is practicing in the community. In majority of cases, they will have connections to the other centers that are doing the studies or participating in the studies. So that's your first port of entry, right? You also, again, should be proactive. And there is a number of websites that list the clinical trials. So National Institute of Health has a website that is called clinicaltrials.gov. So easy to remember. And every single study is required to register, no matter what disease you are studying. Every single study is required to register on clinicaltrials.gov. So if you go on the web, type clinicaltrials.gov and put in Parkinson's disease, and if you want to look for the studies that are testing dyskinesia, involuntary movements. So you can put Parkinson's disease and dyskinesia, and you will get the list of the studies. And further from there, you can actually sort them by active studies, not active studies. And every study will have the list of participating sites. So the Michael J. Fox Foundation has created more of the interactive interface to look for the studies. It's called Fox Trial Finder. And that's where you can, it is strictly focused on Parkinson's disease, and you can customize the search. You can put in you don't need to put any of your personal information. You don't have to put in your email address, but you put in that I'm age 62, I've had Parkinson's for 3 years, and I live in Alabama, or I live in Illinois, and I'm looking for the clinical trials. And it will give you the list of the clinical trials. And then again, you can look at what studies you would qualify based on those generic metrics, and then read about the studies. But obviously, you will bring it back to your clinician, to your physician, and say, I have found this list of studies that I might qualify. So I would always encourage my patients, and Parkinson's patients usually are very proactive, to be self-advocates. But definitely, you always have to check in with your physician.
Yeah, that sounds good. There's a question here in the chat about from Myra. Has the hunkering down of COVID-19 made an impact on current research? Personally, I certainly hope that things have been able to continue, but wonder if it has made a difference and how, hoping that it will be remedied as things improve.
It may, obviously, COVID-19 touched every single aspect of our lives, right? In the way that we've never thought would happen. COVID-19 has immensely affected clinical research, right? We're one of the centers that does a lot of clinical trials. We have 30 plus different clinical trials going on at the same time. We had to stop, obviously safety first. We had to stop any of the live patient visits. We're communicating, not patient, but participants visits. We're communicating with the participants by phone, by virtual visits, but for a number of studies, we had to pause their therapeutic intervention if they had to come into the center to get infusions of the drug or something else. All of that is on hold. So as the country is slowly coming back, that will be resumed. But again, it's a challenge. And for a lot of studies, we'll have to carefully look at the data analysis to control for that gap period when participants were not being able to get their study treatments.
Okay. So since you have such an inside scoop into the world of clinical trials, Tanya, and I, value your opinion tremendously. If we thought about 5 medications or top exciting things that are in the pipeline or about to hit the market, and it doesn't have to just be in motor Parkinson's, not just medications, whatever you choose. 5, so we can go down a list of things or your hot topics.
Okay, let's divide them. Okay, let's start with the drugs that treat motor symptoms of the disease, right? I think that because that is still a need. We're fortunate to have a lot of drugs, but I think that probably the most exciting, not novel, but the most exciting are the therapeutics that deliver a continuous infusion of carbidopa-levodopa. So it's akin to your Sinemet, right? But why infusion and why not to take the pill? Because as you know, for a lot of people, taking the pill does not cover their control of the motor symptoms continuously. And there are a couple companies developing under the skin delivery. It is a needle stick, but that, if effective, that would provide much smoother control of the symptoms. So that is in the domain of achievable, ready, if it works, not conceptually novel, but for many, many years, the investigators were, it was a challenge to develop the liquid preparation of carbidopa-levodopa that could be delivered continuously. Now going down the pipe of non-motor symptoms. And as you know, Parkinson's is not just a disease of slowness and stiffness of movements. There is the whole gamut of what we call non-motor manifestations of the disease. And starting from obviously the most concerning and the most anxiety-provoking cognitive impairment, and will Parkinson's cause my cognitive abilities to go down? There are a couple drugs in the earlier stages of the development that are looking at cognition. And I'm not going to rank order them, but I'm just putting it as the category. Going down the list, going into non-pharmacological interventions, and that's essentially important. There is a study that was funded by the National Institute of Health to look at the effect of exercise in Parkinson's. And all of you know that exercise is your essential prescription, right? But still, exercise has never been studied with the same rigor as drugs. On the one hand, you would say it's common sense. I have to go and I have to be active, right? Which is absolutely true. The study is asking a very challenging question. Will aggressive exercise, and they're asking people to exercise a lot and intensely, in a person with newly diagnosed Parkinson's disease, would it slow progression of the disease? And that study is called SPARKS, and it is being launched now. And it is the first stage 3 exercise study, phase 3 exercise study in Parkinson's disease. And now let's go into the disease modification, which is the area that my expertise is and I'm passionate about. So there are a couple categories. There are therapies that are targeting the protein that accumulates in the cells of people with Parkinson's disease. It's called synuclein. And for the first time ever, we have studies that actually are looking at the impact of delivering antibodies against that protein, whether they would slow the progression of the disease. There are a lot of challenges with those studies, but those are no question very exciting. And another exciting domain, the question popped up, what about gene therapy? So gene therapy is the umbrella, right? You can deliver drugs akin to carbidopa-levodopa through gene therapy, right? So basically you're delivering the vehicle that would produce that drug in your brain rather than you taking the pill. So then it becomes symptomatic therapy delivered by the gene therapy mechanism, right? Or you can use gene therapy to deliver an enzyme in a subset of people with a disease. So one gene therapy is not the same as the other. It is a vehicle. It has to be used very intelligently, and it depends what are you trying to target. Everyone asks, what about stem cells and why Parkinson's is not doing the stem cell studies? And should I go to Center X that is offering me umbilical cells and that will cure Parkinson's? The problem is that on the one hand, Parkinson's is the ideal disease for the stem cells, right? Because how difficult should it be in the 21st century to get the stem cells, make them produce dopamine, and to deliver them to the brain. And that actually, not identical, but that was done with the fetal transplants a number of years ago and did not work. And the reason why that did not work, there were technical reasons, but there is also a reason that, as we talked about, Parkinson's is not just a disease of motor function, right? Which means that delivering extra dopamine through the stem cells is not going to be enough. You need to fix the other chemicals that are abnormal in a person with Parkinson's. And it's like Goldilocks. You need to give enough, you shouldn't give too much, you shouldn't give too little, right? And that's where really we still are struggling how to control that release from the stem cells. Because once you put them, they take the life of their own. Right? So these protocols will come, but again, everyone in scientific community is very cautious about that. So I have one more, right? So the last one, therapeutics that are targeting people with particular genetic mutation in Parkinson's disease. And that really is exciting. And the reason why it is exciting, because we're learning more and more from the field of oncology and from other diseases, that we should not treat every person with Parkinson's as the same disease. Everyone has your own face. Everyone probably has a little bit different biology of the disease. And some people carry genetic mutations associated with the disease. And for the first time in the history of Parkinson's, we actually are developing therapeutics that are targeting particular genetic mutation. So these therapeutics will be applicable to a very small subset of people with Parkinson's. But if they work in that subset, it would be a huge step forward. And then potentially the same therapeutics could be applied to a larger group of people with Parkinson's.
Okay.
Done. 5.
That's amazing. I think you had a few more than 5, but that was really, wow, amazing. There's a question in the chat about molecule BT13. Do you know about that molecule, Tanya? I wasn't aware. I just looked it up. It's the team from the University of Helsinki found a molecule BT13 that boosts dopamine levels. It's a study co-funded by the Parkinson's UK and published in Movement Disorders. Apparently, it's very new.
I do not.
Okay. I mean, there's so many molecules floating around in study in various animal models all over the world with different numbers and
Yeah.
letters. And I find you can spend your whole clinic visit going through these various things. But I think, you know, what you've done today is break down sort of the process and why it's important to wait through the process of study rather than just jumping on an individual molecule. But I think, you know, my sense is, having been in this field for a number of years now and following along, it's a very well organized field in some ways, with a lot of collaboration throughout the country, throughout the world, a lot of amazing doctors and clinicians from bench to bedside that are literally working day and night to sort of help with these sorts of issues, and so many different patient advocacy groups. And I echo your sort of recommendation and call to action with advocacy and you know, empowerment through getting involved with clinical trials. And we had Mike Oken and Bas Blom on in the last couple of weeks, and they've also, you know, been talking a lot about activism around trying to get rid of certain chemicals in the environment and stuff like that. So I think, you know, we need to, as a community, continue to organize and get the word out about being proactive. And it's just such an amazing group of patients, and such a complex disease, I think, as well. As somebody wrote, that it's, Boss had said that it was the most complex disease that he's ever could have imagined. And, you know, I love taking care of these patients, because there's no one patient with Parkinson's that's exactly the same as another. And every day, even in that one patient, it's a different, you know, sort of mix of motor symptoms, non-motor symptoms, and the medications, the applications therapeutically, thinking about the patient in their environment with their caregiver and their family and their, you know, where they're living is just such a fascinating piece of it as well. I was wondering if you could spend a minute, Tanya, talking about these words that are a little hard sometimes for patients to get under their belt to understand. So one is neuroprotection. Another is sort of changing the progression, so disease, and then there's disease modification. These three words are sort of sometimes used around the same medication. There's the holy grail that everybody wants to achieve, which is one of these things. And so can you define maybe those three words as you understand them, and help me understand?
Very good question. And again, they're challenging not only for the patients, they're challenging for the clinical and scientific community, because people sometimes use them interchangeably. So neuroprotection means that you've protected the neurons, the cells, from the disease, from the pathology, right? That means that you have the ability to go in, look at the cell, right? In animals, that is a correctly applied word, right? Because you can sacrifice the animal, you can look at the cells, and you can see whether the cells are alive and look healthy if you've intervened with whatever intervention you did versus not, right? In people, we don't have the way of doing that. So for a number of years by now, the clinical trials have moved away from the term of neuroprotection. So neuroprotection is applicable to the cells, to the animal models, but not, as of today, not in the human studies. Then the next term came disease modification, right? Or progression. That means that you hope that you have kept the cells healthier and more cells alive, but the way you're measuring it with the tools that you have in the clinic, basically our rating scales, how the person is moving, how the person is feeling, right? But if you intervene with a drug, that person is doing better compared to the person who got the placebo ultimately, right? So that's the term disease modification. And it is frequently interchangeably used, disease modification, what was the third one?
Progression, like changing progression.
Disease progression.
Yeah.
Then even more so, even that term is difficult to comprehend. So now, in a lot of cases, we talk about reducing the degree of disability, which I think is the term that very much resonates with you, right? Am I gonna do better in the long run if I take this drug or do this compared if I didn't do that? And actually regulatory authorities very much resonate with that reduction of disability term.
Okay,
They
that's
make it a
helpful.
little bit more in English?
Yes, absolutely. That's helpful. Another question that's maybe hard to answer. There seems to be a huge placebo effect in many medication trials and surgical trials in Parkinson's. And it's often not until we do the blinding of patients and compare things with medication in that phase 3 study that we really see that so much of our intervention, so much of the effect of what we think is helping is really due to placebo effect. Can you speak a little bit to that specifically in Parkinson's disease and why you think there's maybe more effect in our patient population with placebo?
Yep. So Dr. Subramanian absolutely is hitting all the right points, right? So placebo is quote unquote a sugar pill. There is no sugar in those pills, right? But that is the way to blind person who is participating in the study and investigator from their or everything else that is aside from the true effect of the drug, right? And any study has placebo effect, right? You want to feel better. You want the drug to work, right? There is exaggerated placebo response in Parkinson's disease, and that is physiologically driven because dopamine, the chemical that is deficient in people with Parkinson's, is actually a reward chemical, right? So when you feel better, there is more production of dopamine. So that actually exaggerates that placebo response. And in Parkinson's studies, it's not unusual to have 40% improvement just from taking a nothing pill, right? I frequently joke that if we find a drug with 40% benefit and no side effects, let's harness that placebo effect, right? But that's the reason why it is so challenging. That's also the reason why until the moment we do those double-blind, placebo-controlled, and really rigorous studies, we don't know, right? And patients frequently ask me, I don't want to go into the study because I don't want to get placebo. And my response is that actually frequently participating in the studies, you feel better because of the placebo effect and also because of the feeling of altruism. You've contributed, you've taken charge, right? You are actively contributing to your disease rather than kind of passively receiving what is given to you. So that's the placebo response. It's a challenge for the studies, but patients should take it as potential additional benefit, right?
Yes. I love that about altruism. I have to look more into that. I'm a big fan of all of those sorts of things. I'll have to look into it. One other question, word to clarify, biomarker. And maybe you can speak a little bit about PPMI as well.
Sure, absolutely. So, so biomarkers are the measures that provide objective assessment of the degree of either disease progression or the presence of the disease. When I'm being asked about biomarkers, you go for your annual physical, right? You have your cholesterol checked. Cholesterol is a biomarker of your cardiovascular health, right? You have your blood pressure checked. It's a biomarker of your cardiovascular health. You get your blood sugar. That is the biomarker of the risk of diabetes if you don't have the diagnosis of diabetes, and also how effective your diabetes drugs if you're taking medications for diabetes. So all those are the examples of biomarkers, right? In Parkinson's, we do not have those biomarkers. We don't have the biomarkers of the diagnosis. Parkinson's pill, each of you were told that you have Parkinson's disease because your doctor observed you, examined you, and said that you have Parkinson's disease. So it's a clinical diagnosis. We also don't have biomarkers of the disease progression. We measure that today based on the serial clinical exams, and they're pretty good, right? But obviously, observer A from observer B could make different impressions. So that means that there is a range of the assessment. And the more precise we are, the more accurately we can track the disease. And also, the more accurately we can read out the effect of the intervention. So that's where it's very important to have the biomarkers. And the study that Dr. Subramanian has referred to, majority of you probably have heard about it. It's called Parkinson's Progression Marker Initiative Study that was launched by Michael J. Fox Foundation 10 years ago with the objective to develop biomarkers of the disease progression to facilitate and to contribute to the faster and more successful drug development, specifically for the slowing of the progression of the disease.
Okay, that's helpful. Just a question or two from the chat. What about brain donation? Does that help us with anything in Parkinson's?
Thank you for asking. It's called donation because, yes, it is very helpful, right? Ultimately, the only confirmatory diagnosis of Parkinson's is based on the pathology. And obviously, no one has asked you to do the brain tissue collection while you're alive, right? Because that's not reasonable and it's not gonna, our clinical diagnosis in 9 out of 10 cases is accurate. But brain donation can contribute tremendously for us to study the mechanisms of the disease, in some people to confirm the diagnosis, in some people to understand the variability of the disease. And unfortunately, across the board, the autopsy rate has declined tremendously. That's why obviously what some of you have heard about, it's called donation, right? It's contribution of the, when someone passes, of the tissue that is not used by the person, but can have tremendous value for the research.
Why has the autopsy rate declined so much? Do you have a sense of that? Is it a cost issue or people just don't want to?
I think it's combination. We as physicians are much less keenly, much less comfortable or routinely asking people, right? And studies have been done. When you ask the person, in majority of cases, they will say yes. But we are so much reliant on advanced diagnostic imaging of MRI imaging and everything else, we just don't think about it in a lot of cases, right? That's one of the reasons. I don't think that it's the cost. Majority, at least academic institutions, would cover the cost of the autopsy, but there are some costs to preserve the brains, to maintain the whole of the brain bank. But again, it's across the nation, it's across the world.
Okay. Another question about optogenetics. To place a fiber optic light source onto the skull or deep into the brain to turn light on or off to control the electrical firing of the nerve cells. This was in, I think, the Oken book that just was talked about. Are you involved?
I know a little bit. I don't know enough about it to make an intelligent comments.
Yeah,
the person who asked should educate the rest of us.
Yeah. Well, it was in the book, I think, and there's a few references there in the Ending Parkinson's book. I wanted to shift just maybe for 2 or 3 minutes to a population that I know that you and I are both passionate about. It's the women with Parkinson's disease. And it does seem, we talked about getting more people, in these socioeconomic situations and race and diversity representing in these trials, but trial after trial for me, I look at the number of women and it's very disproportionate to the percentage of women that I know have Parkinson's. And I'm just not sure why that is. Is it that women can't take the time out of all the other things that they're doing to be involved? Is it that it would require the male caregiver to bring them in? I just can't. Have you had a sense of this, Tanya?
I don't know. So actually it depends. Women generally as a gender considered to be more altruistic, right? On the other hand, and again, that's, I'm not prejudiced, right? That's, on the other hand, women usually have more caregiving responsibilities, and I believe it's conflict between the two, right? Actually, in PPMI study, we had more women participating in the study. We tried to strategize so that the percent of men versus women was reflective of the general gender distribution in Parkinson's in general. So it depends. But I think that you're asking a broader question, that there are enough data that the disease behaves differently in people depending on the gender. And really very little research has been done to that. Even if all of you know that Parkinson's is more common in men compared to women, right? And if you ask the question why, we don't have the answer to that question. So it makes sense that probably hormonal effects played a role, but we really don't have reliable data to answer that question. There are also certain manifestations of the disease that depend on gender. And only now has there been really increase in the interest and focus on gender-specific progression of the disease, response to the drugs, and so on.
Okay.
And again, Dr. Subramanian, and we're coming to the top of the hour, Dr. Subramanian is very passionate about a lot of things, and really is one of the champions of bringing a holistic approach to care of people with Parkinson's disease, bringing a naturalistic approach, bringing yoga, bringing wellness programs, and among all of these, support groups for women with Parkinson's definitely are on the rise and attracting more and more people, because we need, all of that goes into that personalized approach to the care, which is way, way beyond the pills that we prescribe in the office. And again, commend you for all the effort.
Thank you so much. You're so sweet. Just always so great to talk to you, Tanya. You're just such a wealth of information, such an amazing role model for women in medicine, and such an advocate for these important studies that need to be done. We are almost at the top of the hour. There's been a lot of interest in brain donation in the chat. So maybe PMD Alliance gang, who are magical, maybe you guys can find some resources, especially in Arizona, California, maybe put them up on the website. And happy to do one of these with a pathologist or somebody else who might be interested in that, because I think it's a really important topic that I think when people are searching, how do I do this? They don't get it. The patients get kind of up against a wall and then have good intentions, and then it doesn't get followed through with. So I think we need to get better information and resources out there. And Tanya, if you know of any, we're happy to have you, send us them. I want to give you the last minute or two to give us a message of hope and close the session with us. And Tanya, I want you to know that I'm so happy to have you as an advocate who you not only care about the pharmacology and the surgeries, but you are really a holistic practitioner as well. Tanya has a huge interest in her own personal life and yoga, and has been a great mentor and a cheerleader on the side for all of this sort of holistic approach to this sort of patient population too. So kudos to you.
Thank you again so much. Enjoyed and privileged talking to you, and definitely want to close on the optimistic note. Again, there are a lot of challenges ahead, but the field is moving with unprecedented speed. And truly, the field has never been as active, with better understanding of the disease, with better understanding of the biology, with the development of the new molecules. I'm not promising that it will happen tomorrow, but I'm promising you that we will have better management of the disease. And really, with tremendous respect to the person as a whole, to the family, because it's not just the disease of one person, it's the disease that affects a lot of your family members. With that, stay well, stay safe, COVID will pass, and life will go on. Thank you. Thank you.
Thank you so much for taking the time. Tanya was not only this amazing, yes, no problem Indu, I'll do this. And I have 8 more faculty members that I'll recruit too to be speakers for you. So such an amazing advocate and resource, Tanya. I'm so blessed to have you in our lives. So Andrea, I will pass it on to you to say our final wave. And
Thank you very
thanks
much.
again.
Thank you.
Thank you to both of you. I think we all learned a lot, right? Wave your hand if you learned a lot, and learning new things is good for the brain, good for any brain, especially the Parkinson's brain. So bravo, everyone can go into the weekend patting themselves on the back. And let's wave goodbye, everyone. Thank you again. We'll see you next week. Until then, have a great weekend, everyone. Bye now.